Okay guys, welcome to the second part of the embryology of the limb. We're going to go over a review of the limb bud embryology and just follow on from the first session that I posted a few weeks ago. So I just want to go over this. I'm going to highlight some areas that we just need to be aware of. So during the fourth week, the embryo is segmented, and then each segment consists of the following structures that we're just going to look at. So we've got a segmental neural tube, which we can see here, just highlighted in yellow. We've got a segmental nerve, which we're going to talk about the significance of that. We've got a somite, and then we've got this overlying ectoderm that we can see here. Okay. So the somite itself, so if we just go back quickly, and we can see the somite here, highlighted here in green. So the somite is divided into two pairs, and then we have the dermamyotome, which migrates laterally to form the dermatome, the dermis of the skin, and then the myotomes are going to form the skeletal muscle. So the dermatome is going to form the dermis of the skin, and then the myotomes are going to form the skeletal muscle. Then the second part of the division of the somite, is the skeletome. This contains a cavity of loose cells. This is going to migrate medially to surround the notochord and the neural tube, as we started to talk about, and this is going to form the axial skeleton. Okay. So the skeletome, just going back again, just showing you the region of the skeletome, these cells are going to migrate in different directions. So we're going to get this dorsomedial migration, and this is going to surround the neural tube, and this is going to form the neural arches, and this is what we can see here in green highlighted. So this is the dorsomedial migration. Then laterally we're going to get this formation, and this is going to form the costal elements, and this will start to make a bit more sense as we start to progress through the PowerPoint. And then ventromedially we're going to get this surrounding around the notochord, and this is going to form the vertebral bodies, which we started to discuss in our previous lecture. So the vertebral column itself is derived from the skeletomes, and then the skeletomes surround the non-segmented notochord, which we can see here. Then each skeletome is denser at the periphery than at the centre, and we'll start to talk about that as we also review the other video I put on the musculoskeletal system and physiology of the musculoskeletal system. We can see segmental nerves entering the somites are going to correspond to the skeletome. So these are going to be all of our segmental nerve levels that we've started to look at in some of our previous lectures. Of course, we're going to have blood vessels as well. These are going to be intersegmental, of course, where we've got a vein, we've got an artery and a nerve, because we've got to have vascular supply as well as nervous supply. Then the vertebral centres develop around the blood vessels and form the vertebral bodies themselves. Then we've got this primordia, which we're going to see. The primordia of the intervertebral discs appear segmentally, and here we can see the primordia. So each vertebral body is derived from two adjacent somites, and so each vertebra is formed from the caudal part of one skeletome and the cranial part of the skeleton below. The vertebral number corresponds to the more caudal somite and spinal nerve, and a spinal nerve emerges below the numerically corresponding vertebra, and the intervertebral discs correspond to the somite levels themselves. The neural arches and the costal elements are intersegmental, and then the neural arches and costal elements both migrate from the skeletomes, and then the segmental spinal nerves all lie below the neural arches and the ribs, and the intervertebral foramina are formed by the contributions from the vertebra above and the vertebra below, as we've started to look at in our other clinical lectures or clinical anatomy lectures on the musculoskeletal system. So the cervical spinal nerves are wrongly numbered because we have an occipital which is incorporated into the skull, which we're going to talk about as we talk about the cranium and the bones of the skull. So C1 is the suboccipital nerve. The cervical region has 7 cervical vertebrae, the thoracic has 12, the lumbar region has 5, and then of course the coccygeal has 4. These rudimentary in humans, so this can be more or less. So the vertebral bodies and neural arches are separately determined. So what we have is we have the neural tube that we can see here, and we have the notochord that we can see here, and we have the PAX9 and the SHH in relation to the skeletome. Now this is then going to depend on whether we're going to get formation of the neural arches and the costal element, or via the notochord, via the SHH, the vertebral body itself. So expressions of the Hox gene along the vertebral axis, just to have a basic understanding of this. The Hox genes A, B, C, D, and they are expressed in different combinations in numeric order in a specified segment, and all the more caudal ones. So what we have in essence is we have this expression of these genes which are activated in sequential orders in order for the limb buds and the various other structures to form. So the neural tube induces the formation of the neural arches, and then defects in the closure of the neural tube will also cause failure of development of the overlying neural arches and their fusion across the midline. And then this occurs in certain things such as meningomyeloma, in which we'd get the non-fusion. So a pair of sternal bars form in the ventral body wall. The first 7 rib elements converge and fuse with the sternal bars in the 7th week, and then the sternal bars fuse across the midline, commencing in the most cranial part and extending caudal. And as I've said in the previous lectures and in the lab lectures as well, we have this folding from caudal to cranial, and it's midline zipping during development, which we'll start to see as well as we look at head and neck development. So ossification in the cartilaginous sternum occurs in 5 pairs of primary centres, and this is going to form 5 sternobrae. So let's talk about the limb primordia. So the development in the somatopleura of the lateral plate mesoderm, we've got the upper limb primordium, and this on day 24 in the lower cervical region, and then the lower limb primordium on day 28 in the lower lumbar region. So you can see in the upper region we're going to have this budding forming earlier on the 24th day, as opposed to the lower limb budding, which is going to occur on the 28th day. So early limb development is dependent on the limb bud mesoderm, and so we're going to have a few things that are going to happen in order for this to occur. We're going to have removal of limb mesoderm, epithelium intact, via, we call this amelia, transplantation of limb bud mesoderm to another site, supernumerary ectopic limb, or we can have a removal, transplantation of the limb bud ectoderm, which is going to have no effect whatsoever. And we'll just start to look at that a little bit more as we continue through. So the morphogenesis of the limb, we've got 3 centres in the limb bud primordium. These are going to determine the 3 limb axis. We've got the apical ectodermal ridge, these dermalines as proximal distal segments, the zone of pliozoizal activity known as the ZPA. This is going to determine the craniocaudal axis, and then we've got the dorsal and ventral ectoderm, which is going to determine the dorsal ventral axis. So this is important because we need to be aware of where the ZPA are or how it works in relation to this craniocaudal axis manoeuvring, and the dorsal ventral ectoderm in relation to the dorsal ventral axis. So having an understanding of the folding patterns is very important. The apical ectodermal ridge is an ectodermal thickening, and it runs along the distal margin of the lower limb bud craniocaudally. It's essential for limb bud development, and we've got removal of the AAR leads to failure of limb growth and development of phocomelia. It determines time-dependent differentiation of the proximal distal limb bud mesoderm, and the early mesoderm forms the proximal limb segment, late mesoderm forms the distal leg segment, and this is expresses FGF8, FGF2, FGF4. So the molecular determination of limb bud development, we've got the mesoderm outgrowth, or we should really start by looking at the limb bud ectoderm and how that relates to the mesoderm outgrowth, and how the limb bud ectoderm is involved with the apical ectodermal ridge. So we have the limb bud ectoderm giving off the FGF8 for the mesoderm outgrowth. We have the apical ectodermal ridge giving off the FGF2 to the cranial or preaxial region, and of course the FGF4 to the post-axial caudal region. So in the schematic we can just see the different factors and how they influence the different axes. So the ZPA, or the zone of polarizing activity, is a region of the mesoderm in the dorsal part of the limb bud, and it determines the craniocaudal axis, preaxial and postaxial margin. It maintains the apical ectodermal ridge, and it expresses the Sonic the Hedgehog. The ZPA transplant stimulates the formation of a second AAR and outgrowth of the supernumerary lip, and a retinoic acid implant produces a similar effect to a transplanted ZPA. So when we can just see this in a schematic, we can see a dorsoventral mesoderm pattern is determined by the ectoderm, and here we can see the dorsal ectoderm expresses WNT7A. So we have the dorsal mesoderm WNT7A, in the dorsal region the ventral mesoderm, ventral ectoderm expresses the EN1, and then we have the AAR which separates the dorsal and ventral ectoderm, and then the WNT family is associated with the cell surface and the extracellular matrix, which is going to be very important. So how genes are regionally expressed in the limb buds? So the hoax genes expressed in the limb buds are clusters HOXD and HOXA, genes 9 to 13 in each cluster expressed in the distal to proximal, and then 13 to 19 in sequence. And then we can just see here in this diagram how we have the differentiation between the different clusters. The overlapping hoax genes are expressed in definitive limb segments, and we've got this overlapping expression in the distal to proximal segments. And here we can just see how, for example, we've got HOXD9 giving rise to the region of the scapula and pelvis, the D10 to the humerus and femur, D11 to the radius and ulnar, carpal, metacarpals, D13 fingers and toes. So if for any reason any of these areas were switched off, or they were not transmitting their pathways properly, you could have development to one of the corresponding regions, such as HOXD9, scapula and pelvis, or the D11 radial and ulnar and tib and fib development. So let's talk about the stages in limb development and how it looks and how we're going to see this. So at 6 weeks we can see these small limb buds forming, the upper and the lower limb buds. By the 7th week they're more distinct. There's still no formation in the foot region here, it's still just a plate and the fingers are starting to show in the 7-week stage. By the time we get to 8 weeks, we're starting to see the plates becoming the digits that are recognizable as the fingers and toes. So let's go through this in a bit more detail. So 29 days in appearance, we've got the appearance of the limb buds. 33 days, we're going to get the hand plate, the forearm, arm and shoulder. 37 days, we're going to get this distal plate, thick distal ridge, carpal region, central forearm and arm are going to become more distinct. 38 days, we're going to see finger raise and indentation, or the outline of the fingertips. And then at 42 days, we're going to get the deep notches separating the fingers, and at 52 days we're going to get the fetal pads with the distal swellings of the fingers. So these dates are very important to remember in relation to the limb bud development, because these dates and days are going to be used to assess for normal limb development. So stages of development of the lower limb: it lags behind the upper limb, as I've said, by 3 to 7 days. 32 days we're going to get the appearance of the lower limb buds. 37 days we're going to get the thigh, the leg and the foot plate. 44 days tarsal region and toe raise. 52 days we're going to see the indentations outline of the toes, and 56 days we're going to get this full formation of the toes, hopefully, if normal development is occurring. So let's talk about the flexion and rotation of the limbs occurring between the 6th and the 8th weeks. We've got this preaxial borders marked by the thumb, the big toe, and the flexion occurs at the elbow and the knee. So we've got the rotation of the limbs, we've got adduction of the arm, elbow points caudally, the thumb cranially, and then the flexors anterior ventral. We've got medial rotation at the hip, the knees point cranially, and the big toe medially, and then the flexors posteriorly. So the upper limb undergoes adduction or lateral rotation, or should I say, does the upper limb undergo adduction or lateral rotation? So simple adduction at the shoulder and flexion at the elbow brings the upper limb to a natural fetal position, which we can see thumb cranial, palm facing medially, and lateral rotation brings the upper limb to the anatomical position, the palm facing anterior with the thumb lateral. This is important to note the development of the limb tissues, and this is going to happen from 4 major sources. And we started to talk about the formation in the first video, and we've talked about the basic germ layers and folding. So we've got the lateral plate mesoderm, which is going to give off the structural skeleton, tendons, the ligaments and the vasculature. The somites, or the dermamyotome, is going to migrate to form the musculature. The neural crest is going to migrate and form the Schwann cells, the dorsal root ganglion, the sensory axons, and then the neural tube is going to grow and form these motor axons. The limb bones formed by endochondral ossification. We have the mesenchymal condensation. Then we've got the chondrification, the bone primordium, which we can see here, the bone collar, ossification, and then the primary centres with the synovial cavity and the ligaments, which is going to start to develop up our limb joints. So some important congenital anomalies of the limbs to consider is reduction deficits such as amelia, absence of a whole limb, murmurelia, absence of a rudimentary part of a limb, phocomelia, rudimentary or poorly differential or differentiated limb, hemimelia, rudimentary distal limb segment, adactyle, absence of all fingers, we've got ectrodactyle, missing fingers, and many of these defects of the AAR determine proximal distal patterning, We've got radial tibial reduction defect, absence of the radius or the tibia, plus or minus absence or abnormal thumb or big toe. So it's very important, if we just jump back a few slides, that through our understanding of the stages in development of the upper and lower limb periods, times, we can start to consider some of these abnormalities, why things have not formed. Just following on, we have the duplication defects, the polydactyl, preaxial and postaxial, and this is often a defect in the craniocaudal patterning, ZPA defect, differentiation defects, synodactyl. Some are defects of the HOXD13, which I'll just go back to quickly to show you where we highlighted that. So here we go. Okay. So depending on where the HOXD genes, the host genes are overlapping or expressed, as I mentioned earlier, if there is a problem with signalling, certain regions may not be produced, or may be produced, overly produced, causing extra digits, etc. Some of the causes of the limb defects can be genetic, tetragenic and mechanical. So the genetic causes, some of the causes of polydactyl, syndactyl, brachydactyl, lobster claw hand are autosomal dominant disorders. Many limb defects are components of genetic syndromes. We've got the tetragenic drugs and chemicals such as thalidomide, which was an inadequately tested drug, and there's other drugs that have come out over the years that have caused some of these tetragenic effects, including cadmium. So many chemicals have been used experimentally to study limb tetragenicity, viruses, radiation, hypothermia and hyperthermia. Some of the mechanical causes, we've got amniotic bands, which may cause disruption or amputation of part of the limb, or focal compression or fetal compression, e.g. alidrodomus, the cause of talpias, uterine defects, for example, bicornate uterus. So, with that being said, I just want to go back and just highlight a few of the important things that we've talked about that need to just be reviewed in relation to the first video and the following videos, in which we'll look at the head and neck as well. So please just be aware of the segmental divisions and how these segmental divisions are ultimately going to divide up, and how these divisions then migrate, and through the migration how we have the differential cell migration to form the different components around the musculoskeletal system that we're going to talk about, we have been talking about during our lectures on the clinical anatomy of the musculoskeletal system, and really thinking about the division in relation to the hoax genes, how the expression of these genes form the various patterns of development, and when these are damaged or non-compliant, as it were, the developmental errors that we see, as we've discussed. Stages of development are very important. This is our way of determining that the normal developmental timelines are occurring. Okay guys, well thank you, and I shall be putting on some more videos on the development of the head and neck region, as well as some more basic concepts on embryology and clinical anatomy.